Well, thank you very much again. It's a pleasure to be here. And thank you for inviting me to share some thoughts with you. And I would like to start, therefore, with a short introduction about the COVID-19, emphasizing that, of course, we have all been struck by this terrible virus, and we are all facing it. There is no exception around the globe, and it reminds us previous pandemics, like 100 years ago, when people had to wear a mask at all times. In Europe recently, we have had problems in finding masks. So we have not really made up our mind yet about the need to have one. But we learned a lot from Chinese experiences, and in the ICU, we are indeed well equipped. In the past 100 years ago, we had no treatment. We were recommending to eat more onions and perhaps to use some form of oil, but many patients died in tents like this with a little bit of oxygen and nothing else. So we have made great progress, of course, and yet there are too many people who are critically ill because of this coronavirus. Now, of course, the lungs will be the primary target, and we have seen how we could apply CPAP, high flow oxygen therapy, and even non-invasive mechanical ventilation. We have these discussions about prone positioning even in the absence of invasive mechanical ventilation, and this was proposed already several years ago by our Italian colleagues. However, we also learned that we should not wait for too long when the patient does not improve. We should then carefully plan for endotracheal intubation, as this is not a minor procedure. We should not wait for too long, otherwise there would be respiratory arrest. And of course, we don't want to do it too early, especially if there is a risk of self-inflicted lung injury. There have been a lot of discussions about the type of acute respiratory failure, because initially it was thought to be primarily ARDS, but we learned that the lesions could be relatively localized. It could even be pneumonia, and we learned a lot from CT scanning the lungs. So the management of these patients is not just low tidal volume, relatively high PEEP, as the compliance is not always reduced. So perhaps in some cases we do not need high PEEP levels. We could afford slightly higher tidal volumes, and we should not necessarily put every single patient in a prone position. Of course, there is severe hypoxemia, but it is not so acute at the end, because patients who come in the ICU have usually been sick for a while, and they may not have the typical bilateral chest infiltrates. So that's how, in a recent critical care paper that just came out, Professor Gattinoni proposed to refer to type 1 patients who do not have the typical ARDS, and type 2 patients with the typical ARDS pattern. In each case, we should not allow self-inflicted lung injury, and we may, in some cases, use muscle relaxants. I insist in some cases, as I hear some people giving muscle relaxants in all mechanically ventilated patients, and this may not be a very good idea. So is it ARDS or not? ARDS is just a symptom and may actually not needed. What we learned is that we need to individualize our therapies. And it's not because we put a label ARDS that we necessarily make much progress. That's how in the future we will perhaps not even speak about ARDS any longer. We will have these roundtable conference at our next ISICA meeting, where a number of Chinese colleagues and others will join, and we will discuss these phenotypes of sepsis and ARDS. We could speak about ECMO in our center. It is used quite regularly. It's not the case everywhere, but in the context of pandemics, we may not have the opportunity to transfer patients to ECMO centers, so that there are centers using ECMO without a very good experience. We were interested in this study from Italy, published recently, showing that indeed some patients may not need a very high PEEP level. Some patients may require a very high FiO2. All of this needs to be individualized. We have not spoken enough about the hemodynamic alterations in those patients. We all insist on the fact that we should not give too much fluid when there is such an endotheliopathy with alterations in permeability. Okay, that's correct. But in some centers, people gave too much diuretic therapy, limiting the cardiac output of these patients, and therefore the oxygen delivery, inducing or favoring increasing the risk of shock, requiring vasopressor agents and potentially leading to multiple organ failure. So these patients may be edematous. It does not necessarily mean that we should give diuretics. We need to keep oxygen delivery at a sufficient level to avoid constriction and organ dysfunction. That's how we need to use proper fluid challenges, not liberal fluid administration. No, no, no. We should actually, again, individualize our therapies, evaluating how these patients may potentially benefit from fluids. If they don't, we stop giving it. Passive leg raising test is a little bit more complicated for this, but it could also be considered. And we may have to repeat the fluid challenges over time. So the treatment is not that easy. It's not just give diuretics and make sure that the fluid balance is negative. Management of these patients is quite complex, and there may be a place for an inotropic agent like dobutamine. So measuring SCVO2, the central venous oxygen saturation, could be of some interest, as it could indicate situations where oxygen delivery is inadequate. Now, let's speak a little bit about organization for the next minutes. We wrote this piece several weeks ago saying, you know, just imagine how the situation could be if we have too many of these patients in our departments. And indeed, we know that occurred in China, that occurred in Italy, in some places in France, etc. And this raised the issues of distributive justice. How can we find enough beds for critically ill patients? How can we find enough respirators? How can we find enough ECMO machines? This is a paper that will come out tomorrow, I think, where I discussed the way to adapt admissions in our intensive care unit, leaving patients who are moderately ill outside the ICU and actually allowing patients who are too sick, too old, too altered to die peacefully. Now, this is not exactly like in disaster medicine. We need to plan our action in case of pandemics. I could speak about it for a long time, but our time here is very limited. I will only emphasize that, as we know, there is a lack of ICU personnel and there is a lack of material. So we have learned about the organization, how to call for other nurses, other doctors in our department, in our hospital. Even the head of neurology came to us to help. And we had to remind this neurologist how to manage critically ill patients. But there are also important ethical questions about what we call adaptive therapy, proportionality of care. We should not limit our sophisticated management only to younger people. It's not just a matter of age, it is a matter of taking a number of elements into consideration. They need to be a team leader who will eventually decide. And importantly, we may have to give up on to make beds available and machines available for others. So as emphasized in this excellent review, the principle of the first come, first served in the ICU should not be used. We need to reevaluate the situation at all times. We need to reassess the situation. In Belgium, we do even allow to accelerate the dying process. This is a statement of our society even before the present crisis. So if there is no respirator available or no ECMO available, we may sometimes, it's terrible, but we may sometimes have to take it from someone else. And this finally raises the issue of who dies and how. This is, of course, in a Belgian story of an elderly patient who didn't want to go on the ventilator, and she said, I had a good life, keep this for the younger individuals. That was just a few days ago, as you can see at the top of the slide. So how do people die? It's not necessarily from terminal respiratory failure. I was invited by the Lancet to write this piece on deaths that just appeared a few days ago, where with my colleague Fabio Taccone, we evaluated the process that could lead to recovery with or without mechanical ventilation, with or without ECMO, or death when we decide not to admit in the ICU, or not to start mechanical ventilation, or not to start ECMO when it is indicated. So we propose to the scientific community to better define the circumstances of death of our patients. What is the predominant terminal organ failure? What is the ethical approach that we took? And we must be careful about the cause of death, COVID-19 or an underlying problem. In Belgium, we have many deaths due to COVID-19 because whenever there was fever before death, the doctor usually ticked the box, COVID-19. So we have an over-reporting. We have an excessive report of the number of deaths. Some patients may die from cardiac problems, but as I indicated earlier, some patients may die from septic shock and sometimes hypovolemia. And finally, I'd like to emphasize that we need to thank our colleagues. We have fantastic groups of people who take care of these patients. But we will speak more about treatments in just a moment. And this is a list I wrote in a recent article about possible medications that we could use. And the list is not complete, of course. There are many options. There are many trials on this. And right after this meeting, I will have another conference call with the Belgian authorities about a prioritization of this. In Europe, we have had a lot of discussions about hydroxychloroquine, but not only in Europe, everywhere. We are not sure it works very well, but there are some other options, including, of course, remdesivir, although personally I was not entirely convinced by the recent publication on this. We are also very excited about convalescent plasma. I am administrator of the Red Cross of Belgium, and we start now the administration of plasma from convalescents to our patients. We know the experience is relatively limited so far, but it makes sense. And finally, we will speak about what we call the cytokine storm and the possibility to have a dysregulation that could be part of the septic shock development. And so with this in mind, extracorporeal removal of toxins makes a lot of sense, and we will speak more about it in the next minutes. I was pleased to see that in the US, the Food and Drug Administration allowed the use of blood purification devices, and here are two of them, one from Terumo and Marker, with the Spectra Optia apheresis system and Depuro adsorption cartridge devices, and the other one with the cytosorbents system that is used more commonly in Germany, Austria, than in other parts of the world. So I'm looking forward to have more discussions about these therapeutic options. I would like to reemphasize that we are all together facing the virus, and we should share challenges rather than be in competition. And that's how I am very pleased to be with you and be part of this discussion. So I'll stop here so that we can allow the others to start their presentation. And I should actually stop sharing my screen. But okay, I'm stopping here. Here we go. Have you heard me? I hope.
Well, thank you. Thank you, Professor Vincent, for your brilliant speech. So maybe next, let's move on to the next session. Let's welcome Professor Hashmia from Iran to share about his experience with hemoperfusion and continuous renal replacement therapy on acute respiratory distress syndrome. So welcome, Mr. Hashmia. May you share your screen with your slides?
Okay.
Yeah, just let me know when you need next slide.
Okay. No. Is it okay? Okay. About,
yeah, okay.
do you see? Okay, thank you. And I have to checking everything here. Okay. The effect of hemoperfusion and continuous renal replacement therapy on acute respiratory disease and COVID-19 pneumonia. I am Dr. Reza Hashemian from Iran. And thank you all of the audience for coming and sharing your experience with my country. And about the introduction by February 7, 2020, in the Dr. Masih Daneshvari Hospital in the north of Tehran, is as a referral center for COVID-19 cases in Iran, reported its first case of COVID-19 with diagnosis confirmed by RT-PCR on February 20, 2020, for critically ill patients who were referred to Masih Daneshvari Hospital for being cared in the intensive care unit, unfortunately died due to severe ARDS. The various cytokines were linked to 2090 loads, which were strongly associated with coronavirus disease, 2090 induced lung injury and ARDS. There were significant of elevated production of a wide array of pro-inflammatory cytokines, chemokines in plasma of 2019 COVID, infected patients versus healthy individuals. Hypercytokinemia, also known as a cytokine storm, have been shown to be related and alarming incidence of ARDS and critical illness requiring ICU admission. And the CRRT and hemoperfusion can increase cytokines and inflammatory mediators elimination from the bloodstream and modulate immune function, thus improve the patient's prognosis. This is our study design and participants. Because we have to get in the clinical research ethics committee approval. This study was done in our hospital, which is a specialized hospital for SARS-CoV pneumonia patients during COVID-19 outbreak in Shahid Beheshti Medical University in February 22. We approved by this committee inside the university, and we get this for starting our work there. We analyzed 12 adult critical ill patients who had been confirmation of SARS-CoV-2 infection by clinical diagnosis criteria for COVID-19 and were later confirmed based on RT-PCR assay. Severe 2019 COVID-infected patients were divided into 3 different groups: HP groups, CRRT groups, and combination of HP and CRRT according to their initial kidney function. Estimated glomerular filtration rate based on measured serum creatinine, GFR in the HP group was above 60 milliliters per minute. Okay, we're using the continuous renal replacement therapy machines. We have here 4 machines, and using the Jeffron hemoperfusion therapy can effectively remove excessive inflammatory mediators in the patients. With the extra blood samples were collected in sterile toxin-free tubes from patients with severe COVID-19 pneumonia. Before and after interventional therapeutic techniques, sample destined for cytokine detection were placed in ice and transported immediately to the laboratory for processing quickly. with at least 30 minutes of clotting time, but no more than 60 minutes after the sample collection. Plasma were separated by configuration to 100 gram for 10 minutes at 4 centigrades and stored in 300 microliter aliquots at -7 centigrade until analysis. Serum concentration of IL-1, IL-6, and IL-8 were measured by ELISA by using quantile kits. This is the clinical characteristic of the patients. The A's in the hemoperfusion, 54, and this in the CRRT groups and in the both groups are so equal. And the male and female ratio, you know, in the COVID, we have more male in the groups. And here in the both groups, you have, for example, the 5 in male. And these are the length of a stay. The length of a stay is here between the 7.5 plus 2.1 to 8 days. And this is time to first hemoperfusion and hemoperfusion and CRRT. And both CRRT and hemoperfusions is the time to first time to starting the procedure by hours. This is the survival. The survival in the hemoperfusion group was 1:1, and CRRT group there was 0, and the both group was 3, and the expiry rate was 3. You know, here you see here in the both group we have good survival on expired is 50% of the patients was survived after these procedures. And about the number of CRRT hemoperfusion, this means the days of the procedures. The days of procedures were 1.5 in the hemoperfusion, and for the CRRT 2 days, and for the both hemoperfusion and CRRT was 3 plus 1 plus and minus 1.1. This is blood biochemical parameters of patients. The PaO2 in the hemoperfusion and in the CRRT and the both was measured, and the saturation was measured too. If you're checking all of the saturations and PaO2, you see here in the both group, pre and post, you see the maximum or goes to the both group, for example, 86 and 9 in the PaO2 and the 94 in the post procedure, and in the pre-procedure we had the lower PaO2 here. Again, you see here about the auto saturations too, and for the IL-1, IL-6, IL-8, you see here the diminishing of all of the cytokines here, and diminishing of the creatinine in the CRRT groups more than the others, and diminishing the BUN too. Okay, this is the graphs of the PaO2. You see here increasing the PaO2 after 3 procedures, and saturation increasing in all of those. And you see here this the diminishing of IL-1 and IL-6, IL-8. And the BUN in the CRRT group is diminishing because the time of the CRRT is more than the other 2 groups. In the discussion, we report here a study of 12 patients with laboratory confirmed 2090 COVID infection. Patients had serious pneumonia with developed ARDS, were admitted to the ICU and required intensive mechanical ventilation, maybe non-invasive ventilation or invasive ventilation. Significant elevations in plasma inflammatory cytokines and chemokines were more commonly seen in the severe COVID-19 illness. It is associated with higher mortality in moderate to severe ARDS. CRRT-HP and these combination therapeutic techniques were designed to remove cytokines and other circulating inflammatory mediators from the bloodstream. And the number of confirmed 29 COVID were only 12. This is the limitation level. It would be better to include as many patients as possible in Tehran, in other cities in Iran, and even in other countries to get a clear understanding of blood purification techniques efficacy to inhibit cytokine storms in the COVID-19 infection. Thank you, the professors, and asking you to give me your comments.
Thank you very much indeed, Reza. That was very interesting presentation. So we will keep our question for after the third presentation. And indeed, it's Dr. Singh from New Delhi who will now go on and present his talk on cytokine storm in COVID-19 with the clinical experience of cytokine filters in sepsis. Omender, welcome. We are looking forward to your presentation. Reza, you need to mute yourself. Thank you.
Yeah.
Okay.
Can you hear me?
Yep.
Hello?
Yep.
Yeah.
Yep.
Yeah. Thank you, Dr. Genevieve. So I'll be sharing some of my recent experiences with COVID actually, and I'll focus specifically on the cytokine filtration. Yeah. So the interesting thing is that there has been a lot of information actually. And if you see this critical care exploration journal actually recently came out with a very surprising article that there's a lot of misinformation which is there during the coronavirus epidemic actually. So although at the bedside as a clinician, we are looking for options actually, treatment options, but we have to be cautious, as WHO says, that when you think about a treatment option and a study particularly, look at the methodology in which the study has been done actually. WHO also came out in a shock with they are looking for options actually and quick options, and they want to know what works and what doesn't work actually, but not arbitrary information. They want randomized evidence actually. The also important point is that we are looking for options early in the phase of the disease, because if it is given late in the disease, the WHO experts have realized that it could lead to more worsening of the tissue damage instead of helping the patients. Now let us understand the typical sepsis cascade actually, or a sepsis curve actually. Normally there is an infection, and there are antimicrobials for bacterial infections or fungal infections. There is SARS, and soon there is a CARS, and there is a limited organ injury if the antibiotics are appropriate, and the recovery takes place. But if the immune response is overwhelming actually, you find a lot of organ damage, and which can lead to increased mortality. So we have defined something which is called shock threshold in sepsis actually, which is responsible if this crosses beyond the shock threshold, there is more organ dysfunction and more mortality actually. And you know that number of organs or failure is also directly linked to the mortality. As Dr. Anand Kumar, a friend of mine, said that early treatment actually, early antibiotics, early appropriate treatment, and that is why this bundle concept came up, that we should do interventions as early as possible, and every hour delay in the treatment may lead to worse outcomes actually. So if you compare the same curve actually, if you see the same sepsis curve here, what are the options here? So in bacterial or fungal or other sepsis, we have some antimicrobial therapy which we can use. Here, these are some of the options actually. We have antiviral drugs, remdesivir, lopinavir, and chloroquine. These are some of the drugs which have been tried actually with some benefits. Chloroquine and HCQ has been used worldwide actually. Remdesivir is the only IV preparation which is available. And this we are thinking if this works actually, this is the only option where the threshold here is not shock, but the threshold here is severe acute respiratory distress syndrome actually. So this is the threshold, because we understand that if this threshold actually, with the experience worldwide actually, we have learned that if this threshold goes beyond this curve actually, there is an increased mortality. So we have to flatten this curve as we are doing it by other social means actually. And unfortunate thing is that in terms of the antiviral treatment, the no FDA approved treatment has shown any efficacy in randomized controlled trials for patients with COVID-19. So we understand that there has been concerns that what is killing actually is cytokine storm actually. And we have to do something to treat the cytokine storm. So we have seen that patients who are in cytokine storm actually, they have very high IL-6 levels, and we have to do something. The authors of this paper also recommend that we have to identify this subgroup of patients and treat the hyperinflation using some existing or approved or proven safe therapies and to reduce the mortality. So what are the options? The options are steroids, immunoglobulin, and selective cytokine blockade. These are some of the options actually. WHO, when I started preparing this presentation, had 133 clinical trials which were enrolled, and I just saw today it is crossed more than 600. So how do we address this cytokine storm? What are the options? We understand here that this cytokine storm can lead to worse outcomes, but there could be two subgroup of patients, one who are previously healthy and the others with comorbidities, one with limited comorbidities and other with comorbidities. Patients who are healthy may have higher cytokine storm actually, have higher incidence, and these are the patients where we have to address the cytokine storm. So if you see the entire scenario of COVID-19 infection, there are this around more than around 20% of patients land into critical COVID or severe COVID actually. These are the patients who are likely to die actually. So we need to think something to do, intervene early so that we can save these patients. So if you see the mild to moderate illness COVID, you may have a normal host response and the patient may get treated with whatever supportive care or the standard of care. Patients with cytokine storm actually will have organ failure, and particularly ARDS and higher mortality. Now considering the options actually, with limited options, we have seen that this paper from China actually said that even if you use steroids, which also have a very doubtful role later in the phase of the disease actually, then you find some kind of fibrosis evolving in the lungs actually. This is a biopsy report of this patient actually. So considering this, the WHO also recommends that you should not routinely use steroids, but patients who have got ARDS, you can use steroids in the dose of 1 milligram per kilogram, but that's with caution actually. The other options are convalescent plasma actually, which can also be tried. These are some of the anti-cytokine drugs. The common one which is being used is tocilizumab, and we also had some experience. I'll share you my experience with that actually. So this is something, this is a scenario from an ICU actually, a post from the ICU, and how these COVID patients are behaving differently actually from these routine sepsis patients or patients with H1N1 in the past, the other viral epidemics actually. So the post suggests that they suddenly crash actually. And patients who were just requiring oxygen actually, in next 24 hours, they'll end up on ventilator. And this typically happens after 7 days actually. So they look stable within 7 days, but unprecedentedly or unexpectedly they get worse actually and suddenly crash actually. And that is why this word cytokine storm has been linked as something which happens actually. There's a storm which makes them worse. So one trial which I would like to pick up is the comparison of tocilizumab with CRRT actually. So this is an anti-cytokine treatment which is being studied. Tocilizumab, we had an experience of using tocilizumab in 2 patients actually. So, but there has been a lot of caution actually, a lot of noise from the rheumatology guys actually, that please be careful. Tocilizumab initially may be helpful in patients with CRRT or cytokine storm, but later on it can lead to more incidence of sepsis and the patient may actually die of sepsis. This is the Lancet Rheumatology which says it could be helpful. Unfortunately, the use of these therapies enhances the risk of viral infection, particularly with comorbid conditions, patients with transplant or on immunosuppression. They have very high incidence of viral reapplication with this kind of therapy with tocilizumab. My previous speaker also mentioned about the high volume hemofiltration. Oh, this was just a registry in 2014, the access trial, which showed that there is some benefit actually. Here the benefit was in terms of the hemodynamic stabilization and some improvement in oxygenation, which was observed in this registry. Now, how do we recognize that there is a storm in COVID actually? So we have to see that the patient who is suspected COVID has bilateral infiltrates on the chest X-ray, and they develop respiratory failure. The respiratory failure is very rapid in these patients actually, which can be supported if you send the IL-6 levels. You can prove it is cytokine storm. So clinical manifestations supported by IL-6 levels can help you identify patient with cytokine storm. There are other biomarkers also studied actually, D-dimer, ferritin, which also may be supportive actually because IL-6 is not routinely available. So this is very shocking actually. This is a data which actually I analyzed from a paper actually recently published in JAMA, that 97% of patients on invasive mechanical ventilation died actually. So we have to do something which prevents intubation and ventilation. So this is the window here. As in window, the threshold is shock. The window in COVID-19 is prevention of mechanical ventilation and ARDS actually. So these are the goals actually. What is my experience actually? So I had encountered till now 2 patients actually. Both the patients came just for testing. They had viral symptoms, cough, cold, flu. They tested positive. We got them admitted just for observations. And within 3-4 days, one of the patients with no comorbidities actually started requiring a little bit of oxygen or nasal cannula. Gradually, the oxygen requirement worsened actually, and he required BiPAP. Unfortunately, the patient was not very tolerant to the BiPAP, and that is the time we thought, when the oxygenation was rapidly worsening, we thought it is cytokine storm. We inserted a hemodialysis catheter and we did the cytokine filtration. But unfortunately, because he was not very compliant to the BiPAP, we had to intubate this patient actually. The observation and on the BiPAP, the FiO2 was gradually creeping from 0.5, it went to 1 till just before when we decided to intubate this patient. After the cytokine filtration, after the intubation, the FiO2 came down to 0.6 actually. And after that actually, the FiO2 varied between 0.5 to 0.7. Then we subjected him to another session of cytokine filter. But this time we could not find the same response as we thought it was with the first cytokine therapy. Then we administered tocilizumab in this patient actually yesterday only, and we also decided to give tocilizumab another dose in this patient. So this patient now is on FiO2 of 0.4, 0.5. We are in between after the intubation. In the last 3-4 days, we have done 3 to 4 sessions of around 14 to 16 hours of prone positioning, and his hemodynamic stable. He's got no sepsis, and we have started weaning him off the ventilator. The another patient who is elderly actually was stable actually. He also was on BiPAP. His oxygen saturation was varying between 0.4 to 0.8 depending upon the compliance to the mask, and which was not coming down actually. And then we thought, let's do something for this patient also, because we thought that he's also in cytokine storm. We decided to give toloximab yesterday, tocilizumab. The patient continued to be on BiPAP, but since today morning, his oxygen requirement went to 1.0 actually. So we decided, we have just completed the cytokine filtration, and by evening we will see how the patient responds to the cytokine filtration. Since we had the luxury of convalescent plasma for the first patient, we decided to give convalescent plasma also. We could get convalescent plasma for the first patient. We decided to give convalescent plasma to this patient also. So we have sent interleukin levels before the cytokine filtration for both the patients. The first patient who was on mechanical ventilation, we have already started weaning that patient. He has been off paralysis. He is on sedation now. We are trying to give spontaneous CPAP trials to this patient. The other patient, we are trying to avoid ventilation. We do not want to intubate this patient. So we have planned, we have already given toloximab, tocilizumab. We have done 1 session of cytokine filtration. If the evening we feel that the hypoxia is improving, actually we may think of doing 1 more cytokine filtration and another dose of tocilizumab. We may also think of giving convalescent plasma if the patient continues. We have decided that we have to avoid intubation at any cost, because from the world experience we have realized that intubation is, when the patient is on intubation, the chances of coming out of the ventilator are very less. Thank you so much. So in H1N1 also, thank you so much.
Thank you, thank you. Excellent. Very nice presentation, emphasizing indeed the importance of the cytokine storm. So we have now 3 discussants who will tell us what they think about these important points. We have Professor Ricard Ferrer from Barcelona, who is president of the Spanish Society of Intensive Care Medicine. We have Professor Roberto Tanchanco from Pasig in the Philippines, who is the past president of the Society of Nephrology there. And we have Professor Rafael Avila from Santa Fe in Argentina, who is a professor in intensive care and also extracorporeal systems. So each of these 3 persons will speak, and then we will have a general discussion. So, Ricard Ferrer, you are the first one on the list. Please, Ricard.
Hello, good afternoon, everyone. I hope you are seeing my slides.
Yep.
So I'm going to share our experience. I'm going to be very, very short. Are you seeing my slides?
Yep.
Yeah, okay. So
maybe you can go on the presentation mode, Ricard.
Okay,
yeah.
Okay, right now. Okay, so this is the current situation at Vall d'Hebron Hospital in Barcelona, in my hospital. So as you mentioned before, Jean-Louis, this is the expansion of the ICU. So we are now working in 13 ICUs across the hospital. So we expand the ICU to many other areas. Some of them are natural areas for ICU, like post-op surgical units or trauma ICUs, but some of them are just new spaces like this one you are seeing in this slide that you can see that the medical gases are just made for these pandemics and for attending patients in these white spaces where you can go work efficiently with protective equipment. Also, we have generated a new area, which is a big intermediate care area run by pneumologists. So by now we have more than 200 ICU beds in the hospital spread in these 13 areas. So this is our history. We started with first case the 3rd of March, and we are having cases daily since the 10th of March, and the peak was the 25th of March with 25 ICU patients in one day, and this lasts for the whole weekend, 25 patients per day. And this is the number of cases in the ICU, and we were close to 170 a few days ago, and now we are starting decreasing the number of cases we have in the ICU. And those are the patients in ECMO that are just increasing now when some patients are worsening because pulmonary embolism or nosocomial lung infection, and they need an ECMO procedure because of that. And now we have 8 patients in ECMO at this moment in my ICU. This is the selection of patients. You can see that the most important group is between 50 and 70 years, and the mortality is quite low, below 60, but mortality goes up to 30% between 60 and 70, and 60% above 70. Despite the triage, we are doing an ICU admission. And the mean stay for patients discharged is close to 10 days. For patients dying, it's close to 11 days. And this is the amount of patients we still have in the ICU. We are waiting for the final stay. 21%, so 6.6 patients develop AKI needing continuous hemofiltration. So I know that other hospitals are having higher acute kidney injury rate, but in our case it's quite low, 6.6. So this case has been discussed previously. The hyperinflammatory state or the cytokine storm is quite common in these patients. This is the number of patients we have with these hyperinflammatory states. You can see that the mortality is almost double in those patients having IL-6 levels above 1,000. And those are the patients we select for hemoperfusion. So patients with IL-6 above 1,000 and also with high levels of D-dimer and ferritin. We combine these, of course, with acute respiratory failure with PO2 FeO2 below 100. The tips for that is remember that the clotting of the system is quite common. We are using citrate, but sometimes we have to add heparin to the patient because if not, the clotting is very frequent. And also remember that the levels of IL-6 are quite difficult to interpret if you are giving tocilizumab to patients because levels can increase after the dose of this drug. So this is my last slide. I want to remember that this is a devastating condition. So ARDS is almost universal in all patients admitted in our ICUs, but also some patients have myocardial and cardiovascular dysfunction. AKI is 6.6%. Myopathy is quite frequent after awakening the patient. Bacterial co-infection is uncommon. Hyperinflammatory state with activation of inflammation and coagulation, it's frequent. Immunoparalysis, we are seeing some patients with CMV reactivation and aspergillosis, and sometimes again it's difficult to interpret because some patients have received monoclonal antibodies and of course steroids in some cases, so it's difficult to interpret if it's something coming from the viral infection or if it's coming from some of the drugs we're giving to patients. I have some concern about these medications. I am not convinced that such amount of patients need monoclonal antibodies, anti-IL-6 and steroids and anticoagulation, so it's something that is open for discussion in the future. And of course we have this bioethical discussion, especially when we are having 24 admissions per day. Of course we need to do some selection of patients. Thank you for the attention.
Thank you very much, Ricard. That's very interesting indeed. Thank you for sharing your experiences. So I'd like to move to Roberto Tanchanko from the Philippines. Can we have your thoughts on this, Roberto?
Yes, good evening. It's 9 o'clock p.m. in the Philippines right now. So I'd just like to give you an idea of how COVID-19 is affecting our country right now. So this is the data from the Department of Health of our government, that right now we have 5,223 cases of COVID with 335 deaths. But on the left-hand side, this is the graph. Our first case actually came out back in January 30, but there was a surge of cases starting in the second week of March. And you see here, there are two green dots. The first green dot is when the extended community quarantine was implemented. And you see here that the second green dot is about 2 weeks after the quarantine was implemented. And it looks promising that there's a flattening of the curve that we're seeing, and we're hoping that it will continue. But this is the situation in the institution where I work. You see here the orange bar is about our ICU occupancy, and it's practically at 100% since the start of April. That's April 1 to the current day. The hospital occupancy has been going down in terms of COVID cases, and you see that the cases that are left are mostly in the ICU. The proportion of critical cases in the ICU is going up. So the sicker patients are the ones who are staying. And this has led to an issue for us because we only have so many CRRT machines, so many machines available for ICU patients. So we've had to implement a strategy of just conducting the CRRT sessions for 12 hours at a time, and then scheduling the patients in a way that will accommodate them given our limited resources in terms of machine and personnel. So we have a 12-hour session assigned for them. But we were also cognizant of the cytokine release syndrome, and we tried to implement an algorithm here where if we see the cytokine release syndrome as likely present, we are not able to measure interleukin levels, but we look at, for example, the ferritin and the pulmonary status, and we use that as an indication for initiating CRRT and hemoperfusion. But as it turns out, our incidence of acute kidney injury requiring renal replacement therapy is actually quite high. So most of our patients who initiate renal replacement therapy do so because of acute kidney injury. Now, this is what, in terms of hemoperfusion, I'd just like to highlight that our service has seen thus far about 49 patients. And the 49 patients, the mortality rate in that, these are COVID patients who developed acute kidney injury. And of those 49, we have 7 that were able to undergo hemoperfusion. And I'd just like to show you the characteristics of our patients, that most of them are hypertensive, and the SAPS-2 score is the one that is shown here. And on the left-hand side, we have 3 of those patients are still alive, and 4 of those patients have died. And the 3 patients who are still alive have been there for 18 to 29 days. And 2 of those patients who are still alive have been actually extubated. But they went through intubation, they went through proning. All of them had to have vasopressor support. And these are the various antiviral therapies that were tried. Some of them also received the interleukin-6 antagonist. Well, that's our experience so far with this hemoperfusion. And I'd just like to end with some questions that we wanted to present to the panel. And this includes, first, we have a shortage of hemoperfusion cartridges. We're not able to give it to all our patients. And Professor Ronco in the last webinar was talking about the formula of using 2 cartridges in the first session, and then 1 and then 1, in line with the peak concentration hypothesis. And you want to remove the cytokines as much as possible early on. But if we cannot provide those 4 cartridges, like we only have 3, Does it make sense to use 2 in the first session and then 1 in the next, rather than the standard 1, 1, 1 in other scenarios? And the other question we have is that we cannot do it daily because of scheduling issues. And we wonder what is lost by, instead of doing it daily from day 1 to day 2 to day 3, there will be a gap of 1 or 2 days between the sessions. What is the impact of that on the efficacy of the hemoperfusion therapy? And further questions we have is about the expected effects of hemoperfusion on the following. If you give tocilizumab, is it cleared by the process? Do you have to give a supplemental dose after? And then now our center is also contemplating the use of convalescent plasma therapy, mesenchymal stem cell therapy, and we're wondering about what the impact of hemoperfusion would be if those therapies are being used in the patient. And I think this has been mentioned, the clotting tendency of our patients, it's rather high. And we're wondering about the heparinization protocol that's being used in your centers. We've had to use higher doses of heparin for our patients. And well, that's my last question. That's the end of my presentation. Thank you for this opportunity.
Thank you very much, Roberto. Very interesting presentation and some very good questions that you raised at the end. We will discuss that in just a moment, because now I would like to invite Professor Rafael Avila from Santa Fe in Argentina to present his comments. So he is the only person for whom it's the morning now. So good morning to you, my good friend, Rafael. We are listening to you.
Thank you very much for inviting me to this webinar. First of all, I want to share with you an overview of the current situation in Argentina. Really, we are waiting for the worst, having this preview from the world, which is very scary, very, very scary. We started preparing in our country for the pandemic. The government had established a very strict quarantine since 6 weeks ago, which has been very beneficial so far. But going to the data, we don't have a lot of cases yet. We had 2,277 patients with almost 100 patient deaths. Really, the most concentrated population is in Ciudad de Buenos Aires and province of Buenos Aires. So most of the cases are in both. But the important is to equip all the ICU to receive this pandemic. As you know, you don't have a lot of ICU beds available in the country. 2 beds per 100,000 relation is not so high. And so moving to my presentation, we are working in a protocol of hemoperfusion in patients with septic shock in our hospital, and we are including patients with age 18 and older with PCT equal or greater than 2 nanograms per milliliter, with IL-6, interleukin-6 greater than 900 picogram per milliliter, present on septic shock according to sepsis 3 definition, with high requirement of noradrenaline and need for renal replacement therapy or ECMO. Once the patient was diagnosed with septic shock and fulfilled the criteria to be included in the study, we start in maximum tolerated period to initiate hemoperfusion was 12 hours. We recorded data in T0 and T1. This is the parameter that we recorded. You can see in both boxes. And we performed the treatment with a HA330 saffron cartridges for a period of 6 hours for 2 consecutive days. Our primary goal is to compare changes in norepinephrine requirement before and after the hemoperfusion treatment. Secondly, we demonstrated a decreasing level of IL-6, assessed the total individual chain of SOFA score, established the resolution of shock, clearance of lactate, and mortality rate at 7, 30, and 60 days. So this is our partial result. We collected data of 4 patients, and you can see in the table the severity at the admission of the ICU, 3 patients in CRRT, 1 in ECMO, and you can see the trajectory at the dose of the noradrenaline over time. Just all the patients drop the dosification of noradrenaline, except 1, and I'm going to call patient 3, which the dose grows very high. If we consider the IL-6, interleukin-6, the concentration dropped meaningfully, especially after the first treatment with the cartridge. You can see patient 3 again, just the concentration of IL-6 kept stable and don't decrease so much. And if we consider lactate concentration also decreased after the first treatment with hemoperfusion. Just only 1 patient read with a high level of lactate. I pointed out this patient just because when we analyze this patient fulfill the criteria of macrophage activation light syndrome, which is apparently a very common form of the presentations of COVID-19 with severe pneumonia. If you take a look, these patients maintain the concentration of IL-6 very high, despite the intensity of the hemoperfusion treatment. The patient died after 3 days in intensive care unit. So I bring up this patient because there are reports and publications that COVID-19 with severe pneumonia exhibit a feature of macrophage activation with a persistently high level of IL-6, which is involved in bad outcome of these patients. So this is a short study because we only have 4 patients, but give us a notion of what is going on with this patient with high level of cytokine storm. My question is, might the hemoperfusion reduce the circulating cytokine in severe cases in patient with sepsis? Probably yes, because we proved that. Should the intensity of the treatment with hemoperfusion be prolonged in case of severe pneumonia by COVID-19 with suspicion of mild? We don't know. Probably further study we answer this question, but as the Professor Ben recommend, probably it's better to use 2 cartridges in the first days, and then 1 cartridge per day for 2 consecutive days more. Probably the most important is the first day to decrease the hyperinflammation and the mediator circulating in blood. Is this hyperinflammatory state similar to what we are used to observing in classic septic shock in our ICU? That is a question. I don't think so. Just we are waiting for this patient, and after that, I'm going to tell you what I think about this cytokine storm, new cytokine storm or new syndrome. Thank you very much.
Thank you very, very much, Rafael. Very interesting presentation. As you say, the number of cases is limited, but they are very well studied. So we have now a good 15 minutes for discussion, and that's good because we have many, many questions raised. There are 400 participants, I think, maybe a bit more. And indeed, I have a list of questions primarily related to extracorporeal therapies. But perhaps indeed we could take the last question first and ask, is the cytokine release in COVID-19 relatively similar to the cytokine release in more classical septic shock, which is usually due to bacteria, or is it something different? Now, if you want to speak, you just raise your hand, and before you decide, maybe I can invite Ricard Ferrer to say it. Do you want to comment on that, Ricard?
Yes, please, thank you. So not all patients have this cytokine storm, so the levels of IL-6 is much lower than in patients with sepsis. So here we have very homogeneous populations. However, we have a population with very heterogeneous therapies because in the wards mainly they are using variety of antivirals or anti-inflammatory drugs. So this makes the analysis a little bit difficult. But anyway, I think that IL-6 levels are very high in a small amount of patients, not like in sepsis that the systemic inflammation is part of the definition and is universal. So I think if we are talking about these therapies, we should focus in a subgroup of patients that really have high IL-6 levels and not all patients, because it's not very clear to me which is the reason for multi-organ dysfunction, because in some cases with AKI, the levels of IL-6 are low. And I think it's much more implicated sometimes coagulation than inflammation in multi-organ dysfunction.
Very good, thank you. Reza, would you have another opinion, Dr. Hashemian?
Okay, yes. I think everything is true, and I think this is everything he told me about. This is the fact. Yes, no more reply.
And Amanda, do you agree? Dr. Singh from New Delhi?
Dr. Vincent, there was no storm in bacterial sepsis actually. So we had patients we had some time actually to treat them actually. In COVID, if you see the scenario, and I described one of the patients who came to the OPD actually, and subsequently required a few liters of oxygen within few days actually, landed up on intubation and mechanical ventilation. So real storm actually we are seeing with COVID. And the another experience I had was with H1N1 actually, pandemic actually, where we used to have similar patients where the patient used to deteriorate, actually get worsening of hypoxia within hours and days actually. So real cytokine storm actually has been seen primarily with COVID and with H1N1, but we didn't find actually, we have used cytokine filtration with sepsis, but it has not been an sort of an emergency actually. It has always been planned. We have been thinking, if there was a surgical patient, we used to think, let's get rid of the source control and then do it actually if the patient continues to worse. But they don't used to crash actually. These patients are crashing, patients coming to OPD, requiring little oxygen and then getting up into intubation prone. I think this is the real storm actually, and we have to intervene. Dr. Luis, the most important question is whether we should intervene at the time of life-threatening COVID or we should intervene at the time of moderate COVID or severe COVID. The timing of intervention to prevent intubation and mechanical ventilation, because we understand that the outcome of these patients, like those patients with viral pneumonias of H1N1 pneumonia, is not good actually. So we have to prevent intubation and mechanical ventilation.
So you may use an extracorporeal purification technique, not based on any blood level, but primarily based on clinical evaluation?
Yes, sir. Yes, sir. So what we are thinking is that I think we lost the opportunity in the first patient, that we thought that we have the luxury of time and let's see whether we should do it. And daily we have been thinking, should we do cytokine filtration? And we did not have tocilizumab initially. Now we have procured tocilizumab. But I retrospectively feel that at the time when he had moderate COVID actually, when the patient the oxygenation was getting worse, we should have done the cytokine filtration. And early cytokine filtration like this, the other patient in which we are trying to avoid, I think is the key to this to this problem actually. Because once the patient ends on ventilation, and if you do cytokine therapy or you give tocilizumab, you have more infections. These patients have hospital HAIs more than the patients who are not on ventilators and lines actually.
Yeah, that's another important point. Is it better to give an anti-IL-6, or is it better to remove the excess of mediators which are around? I think it's a very good question. Let's go around and let's ask Roberto Tanchanko if he has something about the identification of patients who may benefit from a purification technique. What would you be your choice, Roberto?
Well, theoretically, using a hemoperfusion where you're able to remove more of the cytokines that are in excess seems to make sense. And the question for me is the timing. What is the right timing for this? Theoretically, I'm thinking the earlier to give it, the better. But there's also a point perhaps that maybe it would be too early. I'm thinking of the cytokine storm as something like a maladaptive response. It's the immune system trying to cope with what's happening, but it's sort of, it's excessive. So if you dampen that response too early, then maybe that's going to be counterproductive. So the timing is really a big question for us. And for us, it's good that we can go clinical for this because in our center, interleukin 6 level determination is not available. So we have to look at these other ways of checking on the status of our patient and trying to hit that timing without the aid of these interleukin levels.
We mentioned perhaps D-dimers, perhaps ferritin. Could these be valuable biomarkers?
Yeah. Well, in our center, we had to rely on those because those are the ones available to us. Yeah.
Yeah. So, Professor Rafael Avila, your turn about what we have discussed in the last minutes.
Yeah, really, we don't have experience in patients with COVID-19 yet, but they're waiting for them. And my question also is, which is the right time to start with the hemoperfusion? But we need some marker to start to differentiate macrophage activation from the classic ARDS for septic shock, for example, is very important. To measure the ferritin is absolutely important also. And I think we are going to start this treatment with what kind of marker? Probably IL-6 and ferritin before to start the treatment.
Yeah. Okay, so we have a number of questions here, but several of them are related to the way we could do it and how we could combine purification techniques with continuous renal replacement therapy. What kind of blood flow, for how long, who would like to share his experience? Just raise your hand and we will move. Reza, your turn.
Yes. About the time of... Okay.
Reza first and then Rafael. Yeah.
Okay. And the first, I think the earlier time is better because we have this experience when we starting the hemoperfusion in the early time of the disease, when we have, for example, the mild to moderate ARDS, we had better result. And when we had the combination of the CRRT and hemoperfusion together, because, you know, in this COVID-19, we have lots of acute kidney injury suffering from the rising of creatinine and the BUN. And we are starting the combined, that was the better situations, and the duration the duration of these procedures, for example, for the hemoperfusion, were 1.5 plus and minus 0.7, and for the combination, it takes time more. And when we are using the CRRT the COVID-19, the creatinine and BRN was lesser, really lesser than the groups that we had the hemoperfusion, the sole hemoperfusion. Then in our patients, when we're using the combination, everything was better, and the earlier time was better in these groups.
Okay. So, Rafael, what kind of flow? What kind of
We combine the treatment with
practically speaking, how do you do it?
We
Rafael?
connected the Hemoperfusion cartridges with a CRT machine. The only thing that we anticoagulate the patient with citrate, that seen that the result that the high risk of clot in this patient, probably we have changed to heparin. Also, you have to bear in mind that
why not heparin if there is a coagulopathy at the same time? Many of these patients have a hypercoagulable state. There is a risk of bleeding too, I know, but how do you choose between citrate and heparin?
You must to balance out both. I probably continue to use citrate and checking the patient coagulation and the clinical state. Also, I'm worried about the time of the connection, because when you use the cartridges and the circuit blood circulating, probably you can produce hypotension in this patient, because you extract more than a half liter of blood. Probably if you are adding up the cartridges volume and the circuit of the CRT volume. Just bear in mind this problem. And then the coagulation, I think I want to continue with the protocol that we have for regular patients with need CRT.
All right. Other comments? Ricardo, would you use citrate, or would you prefer heparin, or any recommendation about this?
We are using citrate for the system, but maybe it sounds a little bit strange, but in some patients the hypercoagulability is so high that in some patients we are still using heparin for patient. So citrate for the circuit, and in some patients heparin for the patient. Some patients again also have low levels of antithrombin 3, and this is something that is important to check.
Very good. Okay. Any other comment about the practicality, about the duration, and also about the number of cartridges? 2, 1, 1, 1, 1, 1. Any other opinion about this? Omender, any comment on this? Rafael?
Yes. I think to use 2 cartridges, at least from our cartridges and the Saffron 330, just because we notice, for example, in these patients, that the level of IL-6 with 6 hours of treatment did not decrease enough. So probably in this case, you had to use 2 cartridges in the first 24 hours, and then decrease the number of cartridges in subsequent days, in my point of view.
All right. Omender?
Yes, sir. So So one thing I just want to make it very clear, that when we use cytokine filtration, actually, it is better not to use with this along with CRRT machine, actually, because we need good flow rates.
Okay.
Although there have been studies with 150 ml per minute, but I think high flow rate, 500 ml per minute flow rate, actually, that will help us getting the cytokine filtered. Lower flow rates like with CRRT, I think will not be very useful in filtering the cytokines, actually.
Okay. Roberto, would you like to add something?
So far, our patients are actually on heparin as 5000 Q12. So when they need CRRT, we use the heparin. We use heparinization. We also use flow rates, blood flow rates of 200 to 250. I think that helps. And we stay at 4 hours for the per cartridge. And then we've been doing the 2 on the first day, and then 1 on the following session, which doesn't always fall on the next day because of the scheduling issues. But as soon as we can, the next session is 1 cartridge.
Okay, we are reaching the end of our discussions here, but there are other questions about, could we use SLED? Could we use it for a given period of time? Who would like to answer that? Nobody? Rafael, you hesitate a little bit? Do you agree?
Well, in our institution, it's an RO water issue. So for the SLED, you'd have to have an RO water supply ready. So yeah, in that sense, actually, the CRRT is easier to implement in the ward, in the ICU. Yeah, there is also the change in cartridge that could be technically a problem that we need to face. Yeah, Reza?
Okay, in Iran, the nephrologist likes to doing the SLED, and intensivists like to doing, for example, other things for the ARDS, for example, a SCOF or other CVVHD when we are using the hemoperfusion, but routinely the SLED not working for the hemoperfusion. Then we don't using the SLED in the ICU, and it is better to using the CVHD for these patients.
All right, thank you. A very last comment, something that we forgot to discuss. Any final advice to the clinicians who are watching us? If not, I would like to thank you very much. I think we had very important discussions and we learned a lot during this 1 hour and a half. And I wish you a very good day, and let's try to help patients even more, save lives and minimize complications. So thank you very much and have a good day, good afternoon, good evening.